Thank you. Thanks. And this is still 11:30, right?
Yeah, exactly.
Okay, great. Hi everybody. My name's Arjun, for anybody who haven't met. This topic is called cardiogenic shock. I was originally going to try to talk about VT, VFib as well, but I think I went on some tangents here and so narrowed the scope a little bit. I did a CC rotation at UW, which I really recommend, and that's where I sort of got a lot of inspiration from this for this talk. And nothing to disclose, and obviously not a cardiologist. So the learning objectives today. So I'm going to try to keep it. I don't want to get too into the weeds. I don't have any like Swan-Ganz cases or anything like that because I think that would just be aggressive. I'm just going to try to keep it to like the main sort of big physiological concepts. Be able to sort of have people be able to talk about cardiogenic shock in a way that sort of makes sense. And I think hopefully sort of provide some sort of comfort when you see someone either on the medicine floor who might have cardiogenic shock in the ICU at Harborview overnight where there's not a cardiologist, or if you happen to be at UW like Card say, hopefully some of this stuff will help. There's a few paradigms that I really want to emphasize. There's a few points that I'm going to belabor, but I'll definitely not do that if time's running out. And then the other thing that's yeah, that's it. Okay, so this is the outline. I'm going to start with well, we'll just go ahead forward. So the first topic is epidemiology disparities and historical trends. So basically, cardiogenic shock has a lot of causes, but the most common cause is ACS. About 60 to 80% of cardiogenic shock is caused by ACS, but about only, which is acute coronary syndrome, only about 5% of acute coronary syndrome results in cardiogenic shock. It's the leading cause of death in acute coronary syndrome. Yes, but there are other causes too, and this is one of the points I'm going to belabor. One of the most important things about cardiogenic shock is understanding the cause. It's very different if it comes from acute coronary syndrome versus one of these other causes I've listed here. Acute and chronic heart failure, which we see a lot in Harborview, sort of at the VA. Even if this represents sort of an acute exacerbation of, I think the most common thing I usually see is like methamphetamine-induced cardiomyopathy, someone with a baseline heart failure and they come in with exacerbation. It's not an ACS type picture, but it still seems it's still very acute. And then these other things, valvular disease, myocarditis. And the reason why it's really important to know the epidemiology and figure out what's going on is because it will determine your next steps in the immediate phase. Cardiogenic shock from acute coronary syndrome is more, I would say, has worse mortality than other causes. These are some Kaplan-Meier curves that show ACS versus other causes. The mortality for the past 20 years or so has been in the 40 to 60% range, and there really hasn't been a lot of improvement. I'll talk more about that in a few slides. One thing is that patients with NSTEMI cardiogenic shock sometimes do worse. And the main reason for that is those people aren't going straight to the cath lab. That's probably the most important urgent intervention for acute coronary syndrome cardiogenic shock is early revascularization, which I'll also talk about soon. Here are some outcomes divided based on sex, race, ethnicity. You can see sort of that some of the main interventions like mechanical circulatory support or diagnostic right heart catheterization is done less in women, also done less in Hispanics. I think that might be sort of for a variety of reasons. I've looked at some data that shows so that that women are diagnosed incorrectly in the field. And that kind of can slow down the whole process. But it's not just in the field that this is the case. I think we just need to be very, very aware of how all the trials and all of the data, not all, but a lot of it was sort of had a majority of a certain population, and we need to make sure that other populations sort of are not being lost because of that research bias. Let's see. Here are the trends that I was discussing. Um, uh, Here are the trends that I was discussing. So the on the left side of the screen, um, you have sort of incidence of cardiogenic shock. Overall, it's rising probably because people are um, uh, uh, sort of uh, cardiovascular disease is becoming more and more of a common problem as people get older and healthier from other reasons. The bottom curve, acute MI cardiogenic shock, the reason why that doesn't go up as fast as the others is because of this sort of one thing that we know has worked the best, which is early vascularization. And then on the right, we talk about mortality here. Most of the papers that I have read sort of cite that there's really been no improvement in mortality over the past 20 years. This is one observational sort of retrospective multi-center study that sort of has a disagreement based on their cohort, but not that much improvement really. So I'm not really sure that we've had no improvement. It seems like that seems unlikely because there's been a lot going on, but maybe that's the case. In any case, it's very, very dangerous situation. I think I saw a question. I'm just gonna see what this was. Oh, right. Yeah. Arrhythmias would be a cause of cardiogenic shock. But I think I'm not sure why that is not sort of represented in the pie chart. Maybe it's because if the arrhythmia causes cardiogenic shock for a short time that resolves, they won't meet any sort of their observational studies. Um, but I'm not sure I have a great answer for that question in terms of what the actual percentage is. Yeah, I would say sort of like VTAC, VFib as a cause of cardiogenic shock potentially could be lumped into acute coronary syndrome, but I don't know that either. That's sort of a guess. So this is a paper came out in 1999 that I've been referring to a few times already, and I won't sort of go into it more, but just that's one sort of big takeaway I'd like is that if anybody comes in with cardiac shock, think about whether ACS is likely and pretty low threshold to go to the cath lab that can be stable for it, because it's sort of, again, the one intervention that's really, really proven to help. There are some studies about whether you should do just the culprit lesion or all the lesions that you find in the cath lab, and the data really suggests just doing the culprit lesion in the situation, because these people are like at high risk of AKI and bleeding and other things, and so you want to minimize that risk while treating. And then this is another point that I'm going to belabor a few times, which is sort of the mortality related to inotrope use. I'll talk about that again more later, but I want to introduce the concept that mortality definitely increases with the number of inotropes. They're used a lot, but there's really no data that says that increasing inotropes improves mortality. Now, it's really hard to interpret these studies for sure because people who are on more inotropes are going to be sicker. But it does come into play when you talk about other potential therapies, including mechanical support, which I'll get to. Okay, so learning points of part one, the most common cause of cardiogenic shock is acute MI. Talked about the racial, sex, and ethnic disparities that exist in the outcomes. Talked about the trends. Talked about the use of early revascularization, and then the problematic nature of inotropes. So number two, recognizing cardiogenic shock. This is I didn't want to spend too much time on physical exam. I'll sort of briefly talk about it, but I think sort of this talk is directed to seniors who are sort of aware of the lab markers to look for. I'll talk about some of my favorite physical exam findings, which are one for cool extremities. You look at the knees. And one thing I really like to do is, that temperature probe that you rub across their forehead. I like to rub it across their knees too, because one of my pet peeves is like when someone says it's cold and then you're like, how cold? And you're like, is it colder than before? And you're like, I have no idea. I don't know if this is definitely not like something that is really validated, but it can help for I think it sort of makes sense. Other things, let's see. Oh yeah, the capillary refill. Is a good one. It's not, I've heard it on like some people refer to this, but when I looked at the study, it wasn't cited a whole bunch. But capillary refill greater than 3 seconds is a really, really sensitive, according to that paper, marker of people who will need like mechanical circulatory support or even ECMO. And yeah, and so I would say that's a pretty good physical exam finding that I wasn't too aware of before doing research for this talk. The narrow pulse pressure is a good one. I think the differentiating between sepsis, septic shock, and cardiogenic shock is a big problem, big difficulty. People can definitely have both. Low EF doesn't mean cardiogenic shock, just like pneumonia doesn't mean septic shock, things like that. And then there is the concept of sort of late stage cardiogenic shock where there's an inflammatory response that causes systemic vasodilation, and that can sort of make it really difficult to sort of use those typical physical exam markers to figure this out.
Arjun, for this, did you pull this from a paper or did you make this? Sorry, I checked out.
No. Sorry, this is from I have a few pictures from this website, so it'll be cited in other places and it's in the notes, but it's from Internet Book of Critical Care.
Okay. Oh,
yeah.
So they're not going to have like sensitivity, specificity, or any likelihood ratios for any of this stuff.
And
it's more just kind of with your clinical intuition and stuff. Is that what they're saying to do?
Yeah, I think so. And I think there's probably no triad of physical exam findings that are really like gonna figure out the problem for you, in my opinion.
No, I totally agree. Megan and I were actually just having a conversation about a patient she had last year who was going into shock and just wondering about, there was some conflicting information, but if we had like this list of other things which could have helped your like pre-test probability and your your post-test probability. It's just an interesting thought. Sorry.
Yeah, no, I agree. I think I love this kind of stuff too. Like the axillary sweat exam finding that's not that commonly known is like very sensitive, and but that's more for probably not cardiogenic shock, but deconcentrated heart failure or other volume overload states. That's a good one. Yeah, and then I love ultrasound, of course. So I would sort of recommend these IVC tests and things like that, and B-lines. Okay. This is a CT scan of an elevated RV to LV ratio. I meant to talk about this before, but one of the really important things in early evaluation of potential cardiogenic shock is trying to figure out the phenotype. I'll talk about that more, but really one of the major things that comes down to is understanding if there's RV dysfunction. Predominant RV shock exists, and sort of LV failure that causes RV failure is sort of important to tease out, because if there really is truly isolated RV failure in addition to isolated LV failure, really the only solution is ECMO at that point. So one of the only biventricular sort of therapies. But we'll get more into that later. And then another CT finding of RV dysfunction is contrast that goes back into the IVC. I just had a patient at Harborview MICU who had sort of the most of this I've ever seen. I wish I brought that into the slide, but it's again a good thing to very important marker to look for. These are some definitions based on trials of cardiogenic shock. Probably won't get into it too much because they're all pretty. I think everybody could probably speak to this. Hypotension, signs of end organ failure, hypotension despite adequate fluid resuscitation, and then some hemodynamic markers or parameters. And then this is sort of a slide depicting what I was mentioning earlier about how heart failure from acute MI is different than heart failure from cardiogenic shock. They just look totally different. In acute MI, it's very obviously acute and probably doesn't present with things like volume overload, sort of a progression of sort of this volume overload to end organ failure, to dyspnea, to altered mental status, whereas that is the progression of heart failure. So I think there were now we're getting to some of these new sort of big discussions in cardiogenic shock that are occurring right now. And one of those discussions is trying to be able to somehow unify these two presentations, so that when someone coming in with cardiogenic shock and you need to figure out the therapies, you can talk about everyone in sort of a similar language. The reason why this is important is because when you look at these two populations separately, if you look at their Swan-Ganz numbers, for instance, people can have the same cardiac output, same right atrial pressure, wedge pressure in these two different sort of contexts, and they have different mortalities and that kind of thing. Oh yes, Connor. Yeah, thanks for following up. Yeah, you Connor put in the line for this patient and was really involved in this care. Thanks for that follow up. That was a really intense case, and I'll probably and later on we'll talk about sort of shock call and things like that. And this is sort of one of the patients that I'm thinking about that we would sort of come across, especially in Harborview. Cardiogenic shock isn't something only for sort of the CCU at UW. It's for things that we'll come across. So, but yeah, but it was good working with you that day. So as I was mentioning, the discussions about creating a new language for sort of talking about all these different contexts of cardiogenic shock or etiologies are the same way. So one is just severity. I'm not going to go too much into this. I was in preparing for this talk. I also watched again Sylvia's lecture on VA ECMO. She talks about this as well. And sort of people who are in the C stage of severity is when you start thinking about ECMO for people. But I think basically there's there's a triad, there's a three axis approach for describing cardiogenic shock, and one of them is severity. And the other is a phenotype, which I sort of alluded to earlier. I think the easiest way of thinking about this is right ventricular versus left ventricular versus biventricular cardiogenic shock. But this was actually studied in a recent paper that used machine learning, so I have to plug that one, which is really cool. And they found three phenotypes, which they called non-congested, cardiorenal, and cardiometabolic. I think that these is very, very similar to left ventricular, right ventricular, and biventricular. But really, I think the way to look at this is in the non-congested phenotype, you basically have not a lot of sort of end organ issues. You might have hypotension and poor cardiac output and some physical exam findings. And those people would sort of do the best. Then sort of one step up is cardiorenal, and the mortality really skyrockets after that if you start having these like AKI. And that you can also sort of conceptualize that as a forward flow problem, left ventricular type problem. And then there's a cardiometabolic subgroup where you start getting sort of liver involvement. And once you have that liver involvement, you're really in the 60% mortality rate in 30 days. And this can help you sort of just again decide how early to use different therapies. This is the same paper, which shows sort of the fact that these phenotypes and severity combinations sort of look the same for people who have MI or heart failure or both. We don't need to go into exactly how to read this paper, but basically one axis is the phenotype and one axis is the severity, and the mortality sort of correlate. So if you use these, you can sort of talk about these 9 different populations in a way independent of their sort of initial insult. I think this came out in 2021. Yeah. And then the third axis here is just risk modifiers. Someone asked a question about arrhythmias, whether they cardiac arrest. Not too much to discuss here. It's not really talked about that much in the literature, at least what I've seen so far. This is not the format of my slide. Not sure what I had here. Okay, no worries. So learning points of part 2, early bedside physical exam is crucial for recognizing cardiogenic shock. Cardiogenic shock patients, I didn't really say this, but they often appear well compensated with ultimate status and shortness of breath occurring as late manifestations. This is to me one of the scariest things. I talked about the different trajectories of heart failure, cardiogenic shock, and acute myocardial cardiogenic shock. And then we talked about the importance of understanding the phenotype. So we're going to talk a little bit about hemodynamics. Again, not going to do any PA catheter cases or anything like that. But the factors that affect sort of cardiac output do include heart rate. It's a very important one. And then stroke volume is influenced by preload, which is also influenced by filling time. You talk about sort of how long you're in diastole, sometimes overlooked. Contractility and afterload. And then again, you want to make sure that we're not sort of conflating afterload of the LV versus afterload of the RV. These are totally different. Preload of the LV can be influenced by sort of pulmonary hypertension, things like that, RV failure. Preload of the RV is really sort of overall volume status, probably. And it gets more complicated. Like if you give an LVAD to someone, for instance, you can overload the right side of the heart with excess preload. And right heart failure is a scary complication of LVAD placement. So I think it's important to think about this preload, contractility, and afterload as sort of in two entirely separate buckets, one feeding the right, one feeding the left. The right heart tends to be pretty preload, say, compliant, but it can stretch to the point of dysfunction, but it's very, very afterload sensitive. And that's usually the cause of right RV failure or afterload. And that's why you get sort of profound dilation of the RV in a PE or something like that. Anybody have any questions so far? Okay. So the PA catheter is a funny topic to me. Some people know about this. There's a trial called the ESCAPE trial that did not include people in cardiogenic shock, but pretty much said no one should be using PA catheters ever. There was not associated with increased mortality. It was associated with increased harm. And the study after study sort of came to similar conclusions. But I have never met a cardiologist who doesn't love a PA catheter. Maybe they exist somewhere. I also did rotation at Cedars-Sinai, and I mean, I've never met one. So question is why? This is a funny paper, obituary pulmonary artery catheter in 2013. And they make a few points here, which sort of in broad scope is basically like we don't really know how to use it. It's not just like on the one hand, there's a lot of variability. They've given like these tests to anesthesiologists and cardiologists and given them SWAN numbers and said, what's the next intervention? And there's a lot of variability there. And then also, it seems that people don't know necessarily how to actually measure it. You look at the waveforms when you do a wedge pressure and you're going through sort of the RA to the RV to pulmonary artery, and people can't recognize sort of the waveforms, and they're measuring the numbers at different spots, and there's all these sort of complications to it. And I think that is probably the opinion of people who say that this pulmonary catheter is useful, is they're saying that we're just not using it right. There is also the statement that says remarkably, when clinicians acknowledge that other practitioners have poor understanding of the PA catheter, the interpretation of the hemodynamic profile derived from the PA catheter, they believe that they have a good understanding in their hands, but other people do not. So that's sort of scary too. That being said, so like everybody sort of thinks that they're great. Oh, wait, what's this? The author of your article on the screen. I'm down. Yeah. So I mean, this guy, yeah, that's funny. I had no idea. I'm not saying I like respect this article really. It's just like something I've seen in a few places. And it illustrates the point. And I think, and it might be that people are just getting better at it now, because there are the sort of punchline is that there are new studies that sort of verify that actually pulmonary catheters are improving outcomes. I don't want to. This is one of the points. This is one of the tangents I was afraid I was getting down to, so I won't. But I'll say that there are newer studies that are showing a lot of benefit to pulmonary artery catheters. And then but then there's still some people who agree with the old sort of adage. And I'm having some, again, formatting issues. That person who wrote Internet Book of Critical Care has a really nice article on this, and they don't really, or actually it's a Twitter. Sorry, this is a Twitter feed. He doesn't really believe in it. This article, for example, reports like some sort of 14% mortality benefit if you use a PA catheter, which would be like 7 times the benefit of PCI. So there's like some weird things, but anyway, I think everybody still uses it. That was a random tangent. And maybe PA catheters are showing an improvement because they're a gateway to mechanical circulatory support, because you pretty much require that if you're going to sort of use these sort of advanced therapies. Can't really read this, but one contraindication to PA catheters I wanted to mention was right bundle or left bundle branch block, because the PA catheter can cause a right bundle branch block. Just an important quick note. And then this is sort of just for reference, some normal measurements for each of the various pressures. I recently learned that this cardiac power output, I don't know if you can see my mouse, but the cardiac power output is one of the things that Harborview uses the most to determine whether someone is going to get mechanical circulatory support. I had a patient, again, in the ICU, who his cardiac index was like 1.5 or something, which is like really, really low, but their cardiac output was just above criteria for getting a device. So they didn't get it. So that was interesting. I'll have to look more into the data on that. And then this is the monitor. I just wanted to show the yellow is sort of the pulmonary artery catheter and a pulmonary artery waveform. It shows the pulmonary artery systolic and diastolic 33 and 14. And if you wedge it several times and you notice that the wedge pressure is the same as the pulmonary artery diastolic pressure, you can stop wedging. But you shouldn't assume that the pulmonary diastolic is the same as the wedge until you've done that. Here is some basic pulmonary catheter data interpretation. And I'm just going to speed through this because I'm running behind. RV dysfunction. So you might, using pulmonary catheter, you can sort of define RV failure, but it's really, really hard to do it. So there's no real consensus because again, a lot of RV failure can be due to left heart failure. So it's really hard to really separate that. UW, I think, likes the pulmonary artery pressure index, which is the systolic pressure divided by the pulmonary systolic pressure divided by the CVP. But not everybody likes that the best. And so there's still ongoing work on figuring out what's the best definition of right heart failure, which is a really big problem because, like I said, right heart failure is sort of one of the indications for ECMO and things like that. Oops. Learning points of part 3. We'll skip that. Okay, so a toolbox of medical management. This is sort of the most important stuff, so that's why I'm gonna try to get through this. We might have to skip the end of my talk, which is okay. So someone's coming in with cardiogenic shock. Think about it in a few ways. So one is just protect the lungs. So sometimes they'll have acute pulmonary edema. Loop diuretics are great. They have an early benefit, not just after you make someone urinate. They have a acute sort of pulmonary vasodilation episode that sort of sucks in the pulmonary edema. So high dose IV loop diuretics should give you some benefit within minutes, not by the time it kicks in. High dose nitroglycerin and morphine are underutilized as treatments of pulmonary edema. I think it's used a lot in the emergency room, but we usually don't have to jump to that on the floor on the acute care service. BiPAP is an interesting, positive preventative ventilation is an important concept. I'll talk about more on the next slide. It basically, broad strokes, it improves left ventricular shock, but it worsens right ventricular shock. Intubation, if they need intubation, it's not a bad thing. It's risky to intubate someone with RV failure. It's risky to intubate someone with hypotension. But if they are intubated, then they support their diaphragm a lot, which is a big oxygen consumer. And so that frees up that oxygen for other organs, which is a good thing. And the type of ventilation you do is lung protective ventilation, just because of the ARDS data that showed that lung protective ventilation, in addition to having better outcomes for the lungs, reduced right ventricular failure by a significant percentage. So we use lung protective ventilation and intubate someone with cardiogenic shock. And then again, if you have RV dysfunction, you can decrease the pulmonary vascular resistance with inhaled EPO. But then maybe you could accidentally overload the left ventricle. So, obviously we're talking, this is the realm of like talking to experts and things, but just so you sort of know the concepts. And then vasopressin, important to know, it's a pressor that spares the pulmonary vasculature. Here's the image I thought is a nice image. Shows how positive primary ventilation decreases return to the RV, and then it sort of compresses the capillaries around the alveoli, so it increases afterload to the RV. So it's basically just bad for the RV. Volume status, again, it's different for heart failure versus acute MI. A lot of people with acute MI might actually be volume down. It's okay to give them fluids, but just be careful, 500 cc's at a time. And if they're oliguric, then they benefit from CRRT. Heart failure, I'll talk about the diuresis plan on the next slide. I think sort of a lot of people are pretty good at diuresis here. There's a couple updates I want to share. This is again from that same website, Internet Book of Critical Care, but I have some papers on the next slide to support this. One thing that might be new is there's a paper that came out in 2022 that showed acetazolamide is a good option, especially if someone's bicarb is rising. And then you can also use this sequential nephron blockade. Is just a good concept that can really get you messed up with electrolytes, but it's definitely shown to make people lose a lot of weight. Spironolactone is listed here, but amiloride I think is preferred when I talk to nephrologists, like especially at the VA, and because amiloride works faster. Spironolactone takes a couple of days to work. I won't talk too much about continuous infusion versus bolus, but they're basically equal in outcomes. Continuous infusion might be a little bit, to me, makes a little more sense, but they're really equivalent in outcomes. And for heart failure, not shock, I like it better because then you can turn it off at night and not make people like hate you overnight. Yeah, so like I said, I'm going to skip this part because I think we're pretty good at diuresis, generally speaking. But if anybody has any questions, definitely let me know. These are the papers I'm referring to. Acetazolamide, Ketoconazole Heart Failure, New England Journal of Medicine, September 2022. And then ultrafiltration, I just wanted to point out, is not a good option for diuresis. It's been shown to be inferior to that sort of diuretic algorithm that I mentioned, that I described about before. Pressors and inotropes. This is a good diagram. Norepinephrine is the first-line vasopressor in cardiogenic shock. Don't go straight to dobutamine. I know for the reasons I already mentioned about the mortality, but also, but it's sort of, if you're going to use an inotrope, dobutamine is a good choice. It's fast on, fast off. There's been a lot of debate about like dobutamine versus milrinone, but that's sort of been put to rest because they're sort of equal in outcomes now. Let's see. Oh yeah, nitro and nitroprusside, really good afterload reducers if someone has blood pressure room, which they often do once you put them on norepi. So the other thing to know about dobutamine is it's a inodilator. So sort of dobutamine and norepi is a pretty common combination. Levosimendan is actually a pretty it's second line, but it's probably like for sure second line compared to other things. I can't remember if we have it in the US or not. There's a lot of references to it. Some of these I think are only in Europe, but I can't remember whether levosimendan is one of those. Isoproterenol is pure inotropy, which is sometimes what you need as well. Epinephrine, low doses, it's usually inotropy. High dose, you get some vasoconstriction too. again, sort of increasing afterload is sort of risky. And the whole point, the whole reason why, I'll go to the next slide now. The whole reason why inotropes are thought to increase mortality is because of this picture on the bottom left, this cartoon. We think about sort of damage to the liver and the kidney, but sometimes it's neglected that the heart is being damaged too. And so the heart has low oxygen flow to itself in the coronary arteries, and you're asking it to work even harder when you give it dobutamine. And that's why you get things like VT, and that's why these things are really dangerous. And so you really, the goal is not to sort of stress the heart out even more, but to actually offload the heart, decrease the oxygen consumption of the heart while still getting a forward flow. And that's where mechanical circulatory support comes in. The role of mixed venous. Again, I think that this could be a long topic, but I think the point is that the most important use of these mixed venous is trending. It's effective. So the only way the best way to use it is to sort of titrate a inotrope, titrate a pressor, and then check the mixed venous 30 minutes later. And then your sort of blood count should be the same. Your oxygen consumption should be the same. Your temperature should be the same. Sedation should be the same. And so hopefully that can tell you sort of whether you got increased cardiac output or not. You can't actually calculate what the cardiac output is because of all these factors that go into the formula of creating mixed venous. It is good though to look at it after making a dose titration, especially because if you're going to use an inotrope, you want to use it for the least amount of time possible. So it's good to be able to assess what you're actually doing with it. It's also a good reason to do a IJ central line rather than a femoral central line if that's possible, because you can't get a mixed venous from a femoral central line. Okay. Learning points. We have 8 minutes, so I'm gonna sort of speed through these things, which I meant to be short anyway, but I think it's important to sort of complete the idea. Valvulopathies are sort of make things really hard, unfortunately. It's really hard to quantify the severity of valvulopathies, especially when there's multiple. This patient that Connor was mentioning earlier had like severe aortic regurgitation, severe mitral regurgitation, and that was sort of the basically main reason why she wasn't a candidate for certain things. Aortic stenosis, really high mortality, a really big problem in cardiogenic shock. The only sort of definitive treatment is replacing the valve. You have to stabilize them though before they can get the valve. There's something called balloon valvuloplasty, which is attempted, but there's not a lot of data on it. And what you want to remember though is that like the main issue is afterload. You need to, if the afterload is high, the aortic valve is never going to open. And so the sort of main treatment management of this is nitroprusside. And I meant to have a New England Journal article on this one too, but there's a New England Journal article that talks about nitroprusside and aortic stenosis, aortic stenosis, decompensated heart failure. But there's no data on it in aortic stenosis, cardiogenic shock. So like when vasoactivations are necessary, but it does help with decompensated heart failure. Aortic regurgitation. This is what's going to cause someone to get shortness of breath and pulmonary edema. The patient that I saw recently, we put her on like 2.5 of dobutamine, and immediately her shortness of breath improved, probably because of her aortic regurgitation was the main cause of her shortness of breath. The key element here is that aortic regurgitation occurs during diastole. So you want to keep them at a high heart rate to decrease diastole. Of course, that's going to hurt other things like coronary perfusion, but that's why these things are so challenging. But one way to increase their heart rate is to put a transcutaneous pacer on them, which I've seen in the CCU. Yeah. Again, we're talking like sort of desperation measures here. And then mitral regurgitation, sort of similar. You have to distinguish between primary MR and secondary MR. Secondary MR can just be due to dilation of the ventricle. And once you sort of get their preload, left ventricular preload better, you might sort of no longer have this element. But sometimes you still do, or sometimes you can't get their preload better till you fix it. And then we have Dr. McCabe here, who's like, that's like his big thing is MitraClip and things, which can be used for either primary MR or secondary MR with various success rates. But yeah, the point is that valvulopathies make things really difficult, and really the only definitive therapy is fixing the valve if it's possible. I'm not going to talk about this dynamic left ventricular outflow tract obstruction. Yeah, because it's super rare. Okay, the shock call is an important thing to say before this talk is over. Whenever you suspect cardiogenic shock, it's good to make a shock call. And that rapidly gets a CCU attending, interventional cardiologist, and ECMO attending, all sort of on a call. We made this call from Harborview. You can obviously do it at UW. And this improves outcomes. These are not like prospective studies, but they do improve outcomes, and they help the referring physician figure out, does this patient have RV failure, OE failure? Does this patient need a PA catheter to figure that out? Does this patient need have contraindications to like a balloon pump? Would this patient need get ECMO? And those decisions are based both on severity and also trajectory. If someone comes in with myocarditis or like a cardiotoxicity from a drug, those things are expected to resolve, and you just need to save them for a few days. That's a great candidate for ECMO. But if someone has acute MI, they're probably should resolve just with revascularization, and they might not need sort of these devices. A lot of these devices actually were shown to not help in acute MI. And then with someone with like progressive heart failure, if they have sort of goals of care that are longevity based, these are the people who might get durable LVADs or heart transplant. Not this, even myocarditis and could get that too, but that's something to think about. So they help you work through all that stuff. Yeah, I was mentioning again why I'm belaboring the point of number of inotropes being associated with more mortality. That's because there's other papers that show early mechanical circulatory support, and those outcomes are better the earlier you do it. So if you start it when someone's on 0 inotropes, the mortality is 68%. I'm not sure exactly the population definitions here, but if you think someone's going to get mechanical circulatory support, the earlier the better. And that's again one of the reasons why these shock calls were developed. A minute or two on some of the options. This is the balloon pump. I don't know if you can see my full screen, but the classic description is you open both your hands and close both your hands, and one is your heart and one is a balloon pump. So in diastole, when the heart is relaxing, the balloon pump expands, and that causes sort of more afterload and allows more coronary perfusion. So that's one big aspect of it. And then in systole, the balloon pump squeezes, and through suction you get decreased afterload during systole, so more forward flow. So it makes a lot of sense. It helps the heart while also decreasing oxygen demand. Has not been shown to be beneficial in MI related shock, but it's extremely common. It can only last like 7 days or so. If you put it in the femoral artery, they have to lay flat the whole time. So some people are trying to put it in the axillary artery now. This is what the X-ray looks like. The impella is basically a small little pump and rotor that goes into the LV and goes through the aortic valve, contraindicated in any aortic valve disease. So it was contraindicated in the patient I've been referring to a few times. There's a few types with different cardiac outputs involved. The biggest one, 5.5, needs to be surgically placed. There's an RV impella too. Not a lot of data for that one. And this has like high hemolysis risks, and it's not an easy thing, but is sort of second most easiest to place after the balloon pump, which can be placed at bedside. Finally, just wanted to mention one more thing about ECMO. Not talking about ECMO really, but ECMO in relation to cardiac arrest. I think it's good at our academic center to start practicing, like if you get called for a code, while you're doing ACLS to immediately start thinking about whether someone would be good for ECMO. I think one time during a code realized that and called them late, and the ECMO team basically said no, it's been too long. Not that that is really standard of care or anything to call ECMO immediately, but we have it, and there's some data that says that early ECMO referral during a code improves outcomes. This is an LVAD, a durable LVAD. Basically, there's like a inflow cannula that inflow to the LVAD. So there's a hole in the bottom of the LV, and it inflows to the pump, and then the pump pushes it out to the aorta. And then it's connected to outside the body through a drive line. And LVADs which could help you control the flow, tell you about the battery life, things like that. These can be bridged to transplant, or they can be destination therapies. That's the end of my talk. These are my grandparents. My granddad had an LVAD. That's the bag that he's holding. He passed away on New Year's Day this year. So I'm dedicating some of this to him. That's it. Appreciate it.
Thank you, Arjun. That was fantastic. And so sorry to hear about the passing of your grandfather, but this is a wonderful way to honor him today. So thank you. Looking for any questions in the chat. I'm seeing some gratitude, and talk was super helpful. Thanks so much. Yep, some love from your co-residents in the chat.
Appreciate that.
Yeah. Well, maybe we can wrap up there.